Hi, Janet.
Hi, how you
Hi,
doing?
Chris. I'm Sarah. I'm going to be your nurse today. I'm just going to take a few observations
Sure,
and do some
sure.
vital signs. Yeah. How's your pain management right now?
It's a lot better, thank you.
It's a lot better.
Yeah,
So you're on the PCA pump. Are you utilizing it? Or?
I was, yes.
Okay.
Yeah,
So
yeah.
out of a scale of 0 to 10, what is your pain level at the moment?
Probably about a 3 at the moment.
So it's,
Yep.
has it gone down?
It
over
has
time?
gone down,
Okay.
yeah. Yeah. Have you seen the doctor?
I did see Dr. Winters outside. I think she's going to be coming in shortly.
Correct.
So,
Okay,
yeah.
okay.
I know you're looking forward to talking to her.
Yeah.
Hi,
Here she is
Janet.
now.
Hello.
Dr.
How are
Winters.
you?
Hi,
Hello.
Kenna. How you doing?
Hello. Okay. Sarah, if you could just make sure that we have some privacy for a few minutes, that'd be
Absolutely.
fantastic. Janet, you know that you came in for your surgery,
Yes.
and what I'm going to be telling you today is probably not the news that you're hoping to hear.
Oh, okay.
Okay, yeah. We normally, with the type of procedure that you're having, we would normally open you up and have a bit of a look first. What we actually saw was definitely not what we were hoping to see. We were hoping to see a small mass that was operable.
Yep.
Unfortunately, when we started the surgery, what we discovered was that the extent of the mass was a lot more widespread than we were expecting it to be.
That's not good news.
I'm sorry, no, it's not great news. It was actually very extensive.
Oh, shit. Can you cut it out? Is it,
Well, experience tells us that if something has spread, metastasised, that it's probably not going to have the best prognosis with it.
So what does that mean? What happens now? Where do we go from here?
Okay, so there's quite a lot of things that we can do. Now, can you tell me how much information you want me to give you right now? I realise that what I'm giving you is probably quite a shock, and there'll be questions that'll come up later, and we can talk more later. But I need to know how much information should I be giving you at this point? Do you want all the information, or do you want pretty much an overview, and then we can go further into
I
more?
guess we just need to know.
what's going on?
Yeah, we've got a holiday booked, haven't we?
Our daughter's in England, she's pregnant at the moment, and we've got, we're going to go for about 5 or 6 weeks in a couple of months' time. And we've got a grandson we haven't seen yet.
Okay. So it's definitely going to be a case of right now you need to focus on getting some treatment. Now, the mass that we saw we would give a staging to, and yours would be a stage 4, which is actually quite serious. Okay? I'm sorry, it's not the news that I would have liked to have been giving you today. I know it's going to come as a shock. It's a stage 4, and we can immediately start some treatment which will help with the symptoms that you're feeling. So that involves radiation treatment, which will shrink the growths, and we can start some chemotherapy treatment, which will help to target the cells. Okay. That's going to give the best option.
I wasn't expecting this.
When do we do that?
Okay, I'd like us to start this treatment as soon as we possibly can, because it will be quite severe treatment. There are some quite significant side effects that come with this. You'll probably feel things like nausea, because it's strong medication. You might get some side effects such as hair loss. What we want to do though is put you in the care of some of the best people in oncology, that are cancer people, and they'll help you with the treatment. And I'll be touching base with you all the way through to make sure things are okay. Now, I know that that's a huge shock, It's not the news that you were hoping to hear today, and I'm really sorry to be the one to give you that news.
You're right, we'll get through this, Liv. We'll get through this, Liv.
Now, anything that's coming like this pretty much out of the blue, and it's not what you're hoping to hear, you probably, your mind's just reeling.
So it was unexpected, it really was.
I mean, at this stage, do you have questions for me?
Can't think of anything, can you?
No.
That's okay.
Can we still go away? Is it still possible to go away?
I think it would probably be best to look at cancelling your trip. Yeah. At the moment, I think the focus needs to be on your own health. You need to try and focus on Janet taking the treatment.
Oh, sweet.
Now, what I'm going to do is just give you a bit of a chance to get your heads around this news, because I know that it's terribly bad news. And I'll come back about 2 o'clock this afternoon and we can talk more. Okay. Again,
Yeah.
I'm really sorry that it wasn't the news that you were hoping for. There is quite a lot that we can do.
Thank you.
Okay.
Oh, shit.
I'm sorry, Janet. I know that was a lot to take in. Can I get you anything? Do you guys have any questions?
Anything?
Is there
Lots of
anybody
questions.
you want me to call?
No. I'll give my daughter a ring.
I'm so sorry.
Have you seen Oscar yet?
We haven't. There's so much to do.
Oh, sweetheart.
These sorts of simulation scenarios can bring up feelings for people, and there are services if you've got anything that you feel that you'd like to discuss. So I'd like us now to reflect on what we saw and maybe think about how you felt about how the patient and her husband were presented with the diagnosis, what they were thinking.
I think from a personal experience I've had, that you generally feel numb to start with. Absolutely numb. That you don't know what to say, what to ask. And that happens later, considerable time later, when you've had an opportunity to absorb what you've been told and actually reflect and think on it. So initially with that sort of news, I think you'd just be numb, absolutely.
Absolute shock and disbelief. Yeah.
You'd only hear a percentage of what was said anyway. I think there was a video in the pre-readings where it was just like white noise after the initial conversation. Yeah.
What do you think went well about the scene? Anything?
I think same as personal experience, sometimes you'll walk in and it can almost start with a smile or something sometimes, and you're reading everything from that first encounter, and that you're like, oh, maybe it's not as bad, and then the conversation goes on and it takes a minute for your mind to catch up with the words. So I think it was very obvious from the start that it wasn't going to be good news, and your tone stayed pretty much the same.
Yeah.
The way that you asked what the amount of information they wanted was quite good, like, because they are numb. They have no idea what they want. So it's better to come back. And the fact that you set a time for them to go back to them so you could answer their questions is always good.
Yeah. I was just thinking though, maybe that wasn't a good idea to say a time, because doctors get busy, and if you didn't come back, I'd be annoyed. If I had heard that you were coming back at 2,
Good observation, yeah.
then you didn't come back at 2, I'd be like, oh, frustrated. As the partner that probably did hear that.
Yeah.
Sorry.
No, it's actually a really good observation, because if right at the start of that part of the patient's journey, I've given them an undertaking and then failed that, it's probably going to set them up with every time I'm promised something, it falls apart. So it's a fantastic observation.
You kind of never really gave a prognosis to the patient. So I guess it's like an open interpretation. So you've said, oh, you know, we would say this is stage 4, but what does stage 4 mean? You didn't really say to them, okay, stage 4 is kind of, you said it's serious, but how serious? You said it's metastasized, but to where? There's like, I mean, you asked them what kind of information they wanted, but you didn't really give them, obviously the patient probably knew where you were looking for that, but as you know, we didn't know where you were looking. We just got stage 4. So my thoughts were, how bad is stage 4? They were obviously going overseas and you said, you know, you need to cancel that, but you never gave a time frame. So like obviously once they start seeing their oncology people, they'll probably get a better idea of like how long the process is going to take. But for me, I was kind of like, well...
What does it mean?
Yeah.
Yeah. Great. Okay, so what's the first thing that they're likely to go off and do? Google. Yeah. And is every piece of information on the internet 100%? No. So it's a big risk. Yeah. Yeah. So giving the information in small chunks in a way that the patient can understand, and very much working on the fly and gauging how they're going and processing that, because obviously they're being overwhelmed with emotion, and that's going to impact on their ability to take anything in. They've got a huge cognitive load just from the shock of everything that's going on. So I think it's very much a balancing act.
They wanted to know if they could go and see their grandson, and I think it would have been nice to sort of say, if you don't have the treatment, you've got 3 months maybe. If you do have the treatment, you've got a possible 10 years or something, because realistically they just got told, oh no, cancel your trip for the treatment, you're going to be sick, you're going to have this, you're going to have that, but you didn't give a reason for the treatment, like how that would help.
And so by not giving them that, they're sort of freaked out about how long do we have? Well, we've got no sort of time span.
Yeah.
And they've only got like one small piece of puzzle. So she's going to be thinking, well, how long has she got to live? Is she going to meet the grandkids? Like in that situation, there's a whole heap of questions that are going to come to that, and they haven't got the answers yet. So they're going to be overwhelmed and burdened by those thoughts that they haven't, you know, the daughter's asking that they didn't think about at the time.
Yeah. Exactly. And I think it's even worse when it's someone that's a long way away, because there's that feeling of helplessness that you're in a different country, and that even if you were to drop everything and come straight away, there's all those arrangements that need to be put in place, which is a real challenge.
And obviously they can't see them physically, so, you know, your support can only reach so far, I guess, whereas if you know, she had, say, 4 weeks to treatment and then she thought, oh, okay, well, maybe I can go over there. They've got at least that little glimmer of hope of what's going to come ahead. So
yeah, and hope is important. How did you feel sitting there observing those sorts of reactions, though?
For me, it brought up memories when my grandma had cancer, so I felt very, I was very empathetic towards it, so it brought tears to my eyes, because in my experiences and my memories of when I was younger, and remembering my pop feeling that's having the same thing holding his wife's hand can be very upsetting, and it's very shocking. I think with the news they weren't hoping for, obviously, so Corey would give them no hope or no faith towards the future. So the same thing, my pop, he got told maybe a year.
Yeah.
And it might get worse, but then she had 3, so he had a very young doctor he had 2 different doctors telling him 2 different things. One doctor saying there's no point doing chemotherapy, and a younger doctor saying, why not do chemotherapy? And so I brought a lot of memories back to me when I was younger, getting told in summer holidays that Nan had cancer. So that's what I felt.
I have an experience. My great uncle got diagnosed with cancer when I was working on the haematology oncology ward, and I found it so hard because I myself, being a nurse, wanted all the information. I wanted to know from everything what could go wrong and what were the options, and it just, watching that brought it all back, and it was just like, it's that feeling as a health professional, you want to know all the info. You want to know what you're preparing your patient for. It's hard being on the other side. It's not easy.
So Janet and Chris obviously had a very good nurse that was right on hand. who was able to just check their understanding of the immediate situation and offer some counselling. Would there be any other health professionals that might be useful to get involved at that point?
So I'd say definitely a social worker at this point. If anything, they're just like for an assessment, they can kind of direct, what services are available, and where they can basically get it and organise those things for them. On one of my pracs back in Victoria, I was looking after a patient who just found out he had a liver tumour and basically got given 6 months to live. So I was the nurse that came in afterwards and, was like, they just kind of slipped the information to me and I kind of went in and, like, how are you guys feeling? The daughters were all in hysterics and stuff, and it's hard to gather your own thoughts in those situations and to give them, okay, well, these are the people that you can talk to. This is what services we offer. If you need anything, just let us know. Because in a lot of instances, they lean on the nurses and say, well, can I just talk to you? And it's like, well, yes, you can, but I'm only limited to a certain amount of resources that I can access, whereas this person in this department has more information about the wider community access and things that we can do for you now while you're here, and then they can also implement things for when they go home with their families as well.
The palliative care teams are fantastic for anyone that gets diagnosed. They have a social worker, they have nurses, they have doctors, consultants even, that are specifically for the palliative care team. They are the ones that you always refer to if you can, because they're the ones that will give them the information of if we want to take them home, how do we go about it and stuff like that. They have all that info.
My experience of the health system is that quite often the consultant looking after the patient may not engage with the palliative care team very early in the piece. Is there an optimal time to get palliative care involved, do you think? I mean, Kim spoke about advance directives and how potentially that would be a conversation that you'd have almost immediately on diagnosis. But judging from Janet and Chris, it might not have been the best time on top of the fairly devastating news that they'd had to turn around and say, oh, okay, well, right, so stage 4 and cancel your trip and advance directive.
After giving them the news, wouldn't you give them time, maybe like a day or two, to think and process and talk with who they want to before you got more people in their room and in their face?
Yeah.
Because I think if you've just been told something like that, the last thing you'd feel like is a bunch of people in your face telling you this, that and the other, like you're still unsure about things.
Mm. Yeah, so you're still processing the information that you've been given.
So you could maybe offer them, we have these people here when you're ready for them. I don't know. I feel like that would be the last thing I would want, is all these people in my face.
Suddenly all these strangers who...
that you don't know and you're uncomfortable. You're uncomfortable as it is, so you wouldn't want all these people around you telling you things, I guess.
And in some way that might be quite disempowering because you're sort of being funneled down a pathway. Yeah.
I think from a personal opinion, before I started my nursing 2 years ago, I thought palliative care was dead. Like they're basically saying you're dying, so we're just going to shove you in a hospital bed in the corner and you're just going to die there, kind of thing. So maybe like in the doctor's 2 o'clock meeting when she comes in, obviously she's going to come in with some more information about the cancer and the treatment options, that there could be a brochure for palliative care in there and just say, this is something that you need to think about for the future. Now, palliative care isn't death and dying, it's keeping you comfortable, and those people actually have more resources and more knowledge than, as a general ward, and that's just my opinion. I've worked with a few palliative care nurses and their knowledge, I put them in the ball game of anaesthetists. They're so cluey, they know more about the medications and what works and what doesn't work and what they can do more so than we do, that general nursing, I guess. So giving them the option, but giving them the knowledge that it's not what you may think it is something that is going to be beneficial for you in the long run, but here's the information now, so you guys can put together your game plan of, you know, what's going to happen, when it's going to happen, and you've got some information to tell your family that you're about to go and tell the bad news to.
People have very different reactions to the type of news that we've just given to Janet and her husband Chris. Some people very much gear themselves up to fight the cancers. Other people have a completely different acceptance of a diagnosis like that. So I guess the thing is that it's an individual journey, and everyone's going to react differently. And it really is a case of steering your way through things. So if you were the nurse that Sarah portrayed this morning, in your role as a nurse or a healthcare professional looking after Janet, how would you have reacted?
I personally would have stepped out and said, I'll give you a few minutes just to absorb the news. When you moved your chair closer, I was just like, oh, get out of their faces, you know. So I think it comes down to what's your role at that time. Social work might come later. They're more trained into these things. So yeah, I know, you know, as nurses we care and that's what we want to do and be there for them. But at the end of the day, you're still a total stranger that just came up on shift. So personally, it's like, can you just step away for a few minutes? But like I said, you understand totally why you want to help and be there for someone. But I thought that was a bit in their faces. Sorry, Sarah. Okay.
I was just going to say, it probably depends on the level of rapport that you already have with them. I know quite a few times, even as a student over a 4-week period, right at the end, I cried with the family. And at first I thought that I was going to get in trouble and that it was the wrong thing to do, but it didn't feel wrong. The family were quite receptive of it, and we had built a rapport over the 4 weeks, and it was quite a sad time. So I think it really just depends on that. And you can gauge from the family's like body language if they don't want you in the room generally. So yeah, it would just be a matter of sussing it out on the day or who you're with. But yeah, I cried like a baby, and they cried with me, and it was kind of a beautiful thing in the end, but I was worried as a student that I would get in trouble.
That was such an interesting insight. Can we just dig a tiny bit deeper into why you felt you would get in trouble for crying?
I was worried that it would blur the boundary of professional and a therapeutic relationship. One of our competencies in our book is to be able to start and stop that therapeutic relationship, to sort of leave it at the door when you go home. And you do to a point, out of self-preservation, I did. But you come back and you do have those patients that you think of over the night, and then you come back and want to check on them in the morning. I think that's just human nature. And for me, personally, that's not something I can get rid of, and I don't want to. My thing that I'm going to have to focus on is I can't fix it. Like, I'm a fixer, and I can't fix that, but I can do things along the way to make it better for them. But yeah, I was worried that it would just blur those professional boundaries. That's why I was worried that I might get in trouble.
I actually had a student very similar to you, and the family after the student had finished had said to me, it was so nice that the student, like, she could see the student was welling up and everything, and she said, it's okay. And the student, same with you, sat there and cried with the family. And afterwards, the family said it was just nice to see that someone cared for their mum as much as they did, and we were working towards coming up with suggestions and solutions. But one thing that we always tried to do was we used to give them a piece of paper and a pen, because family members always come up with questions that they have to ask, and then the doctor comes in the room and they automatically forget them. And it's the most awful thing, because then they go to you afterwards, oh, I had that question, or I had this question. And it's just like, so if they have a paper and a pen, then they leave a space and they know the questions that they want to ask when someone's going to come back.
So what strategies could you possibly have in that awful time where Janet and her husband, Chris, have just been given this pretty bleak prognosis? How can you help them deal with what it is that they have to deal with?
I think just being a presence for them, obviously I didn't find what the nurse did over the bounds, but I mean, just being in the room, in the corner, maybe fluffing the pillows or something, letting them know that there is someone in the room thinking of them other than their family, because obviously the family is more involved in the situation. Whereas a nurse, we have our professional responsibility as well as our own emotions, but our emotions generally aren't clouded by the unexpected news that they've just received. So letting them know that without directly being in their face, that you're in the room there with them, gives them that feeling of comfort and protection, knowing that someone is there, but they're not in my face, hey, how are you, what's feeling, what do you want to do kind of thing, just gives them that sense of comfortability in there.
Yeah, and Nurse Sarah could also make sure that they weren't interrupted by anybody else coming into the room while they were trying to deal with that sort of information, and just give them that space that they probably just needed to have a bit of a cry together.
The challenge is to fight the temptation of telling them it's going to be okay. So I think what she said is good to use the power of silence, as in being in their presence, empathizing, but also not in their face and saying, oh, sorry, it's going to be okay, because I can easily do that. So that's very good. So to deal with our own emotion and also empathize with them and not telling them it's going to be okay when it's not going to be okay. Yeah, that's very good.
You're bringing up something that's really important, and I think we touched on the use of some jargon that happened there, the stage 4 type stuff. But quite often some of the language that's used around palliative care is a bit wishy-washy. You hear people comment on, oh yeah, she's going to pass away, or she's spiralling down, or she's gone to a better place. And is that good or bad?
It depends on the culture, because some religions, some cultures don't talk about the dead, and some cultures might not believe certain things, or some religions might believe certain things. Like you say, if you're a Christian, oh, she's gone to a better place, and obviously speaking about heaven, but someone else that could be totally something different, that they might not think it might not be a better place. And it also depends if the family's beliefs is also the person who has passed beliefs, because that person might not be that same religion. So you have to be respectful, because you can't say something like that, or because there was Aboriginal that died in my sister's community and no one spoke about it. There was nothing spoken about it, and she was very confused. And so it's a very touchy subject that you don't speak about that now, and you just don't speak about the dead. And that was something that my sister learnt really strongly, that it wasn't just something she's heard like a rumour, it was actually really true. And so I think it's just being careful.
Yep, so being aware of the cultural beliefs of the person that you're looking after and trying to be respectful of that, but not give false hope. It really is a minefield.
I was going to say that I think it's always better to be frank. Like, I worked on a palliative care ward as an AIN, and we had one, I don't know what the nurse said, but the family came in thinking that he was actually still alive and he'd actually passed on. And it was, I don't know what happened, but it was very awkward just being in the ward at the time. It was, so I think it's always better to be frank with the family, anyone.
Not give that false hope.
I feel like not giving false hope is something like we have to learn though, especially as someone who's young and like not a nurse before. You always, everyone's always told you, oh, it'll be okay, like even when you're young, and everyone's so used to saying, oh, it'll be okay. But I think that's something you've got to learn not to say.
Yeah.
You've got to learn to be like realistic, I guess, without hurting someone even more than they already are.
I mean, I certainly would think that for the nurse it would be fine to say it's okay to cry.
Yeah, but you can't just say, oh, you've got stage 4 cancer, but you'll be okay. Like, you can't, Yeah,
because that would be terribly misinformation.
Yeah, exactly. It's something you learn there as you get older and more mature.
And certainly there are people in the world that will take significant advantage of people that really want hope at all costs and offer them some fairly unempirical treatments.
When I flew, my dad fell really ill at home in Ireland, so I flew from here, and my family had about 36 hours of knowing his prognosis before I got there. And when I landed, I remember meeting with this nurse and was like, oh, I really need to use the toilet, like I'd just gotten off the plane. So she was like, oh yeah, here's the toilet. And, you know, I'd had 24 hours flying to get my head around what was happening. So when I landed, I was quite weirdly chilled. And when I came out of the bathroom, she stopped me and she was like, look, this is what's going on, you know, this is what he's going to look like. And basically told me to my face that he wasn't going to survive, which I knew anyway. And when I walked into the room, there was like 3 nurses just lined up against the wall, and they like knew that I was the one that had landed from Australia and whatever, and they were so upset. But in hindsight, I actually get a lot of comfort from that, because like one of the girls said, it's like my dad obviously made an impression on them over the 2-3 days that they knew him.
Yeah. And it can be very helpful to explain to someone that, you know, they might be in a room with tubes and machines that might make them look unfamiliar, or their appearance might have changed because of the disease. So I think that might be something that as health professionals we can give to the families. Right, any other insights? Is there anything as his doctor I could have done better? Better information, better language, more information?
Although you gave a follow-up time, I think maybe just sort of like staying for a few minutes to see how they went, because you left it with the nurse who looked a little lost, and it was just sort of like, oh, you know, can I help or whatever. But a lot of the time, patients want to talk to their doctor. They don't want to talk to their nurse. They want to talk to the doctor because they're the ones that's given the prognosis, and they're the one that's going to give them the treatment options. Just sticking around, even if you just sat there quietly for a few minutes and then said, I'm going to give you some time, maybe they would have said, how long is this like? They would have asked those questions that we're asking now, instead of stewing on them for the next few hours.
And you whispered something to the nurse. I'm not sure if it was just, have you got them, are you okay? But I would have wanted to be privy to that. I would rather you have said out loud, I'm going to leave you in the nurse's hands, Nurse Sarah, sorry. Yeah. Is that all right with you? Rather than, it was just a really quick whisper, and I would, maybe, it could have been anything, and I wouldn't know.
These are great insights, yeah. Because it's often easier to see something and then be able to debrief on it and go, that's what would have been better. Maybe that's where we need to be moving towards.
Yeah, I had another situation where I was 18 weeks pregnant and I'd lost my baby, and so the doctor was confirming it on the ultrasound, and so we were finding out in real time that it was, you know, definitely the baby had died. And so, but I understood the doctor was visibly upset for himself to find out the information and to be having to tell me that. And I could see that he was trying to be professional, but he was also being a human being. It was really it was very appropriate. He was professional, but he was also responding to the situation. But then he said to me, I'm going to go, but I'm going to leave you with the nurse. But for me at the time, so it sort of comes down to everyone's different and every situation's different. That was appropriate for him to have done his bit as the doctor and give me the diagnosis, and then he left me and my husband with the nurse, and she gave us plenty of time, and that felt, you know, right too. So I sort of felt like what you did then in that situation reminded me of my situation where the doctor gave the medical information and the nurse was there for the follow-up support.
And we tend to forget, probably because the mystique is perpetuated, but doctors make mistakes. Doctors don't get it right all the time. And certainly as the doctor in that situation with a lovely, you know, reasonably youthful woman who'd come in thinking that, you know, her symptoms were going to be sort of quite easily fixed by this thing called a Whipple procedure, which no doubt they Googled Mr. Whippy. They're the sort of people that you do really engage with. They're obviously lovely people. Their daughter's, you know, having a baby. They're looking forward to the rest of their lives together. And to give them that sort of news is just horrible. Yeah. Nobody wants that sort of an outcome for their patients. So yeah, I guess the take-home messages are that we're all imperfect, we all do the best we can, we try and run with the situation as best as possible, that using some of the pointers from that spikes procedure, where you've got a bit of a structure around what you're going to say, can be helpful. And feeling that it's okay to care about the patients. So, having really cheered everybody up enormously, I'm just going to show you a little video, if I can get it to work.